Good afternoon, everyone. So, the next topic is going to be management of ECMO. So, myself, Dr. Rakesh, I am from KIMS Hospital, Secunderabad, critical care and ECMO consultant. So, as usual, the conflict of interest. In the next few slides, I'm going to discuss about the management of ECMO apart from your routine management things. So, what are the things you need to keep it in mind? What are the things you need to do so as to have a good and safe outcomes of ECMO? So the objectives of talk is divided into initiation phase, maintenance phase, weaning phase, post-weaning phase, which is also important. So initiation phase, apart from your routine things, what you are doing to do. I'd like to say that keep an ECMO crash card prepared and keep it ready on the bedside of every patient. Because we don't know what are the complications which you are going to face during initiation, because the most important step in the ECMO, the success is your initiation. So how smooth the initiation goes, the ECMO run goes, and then the outcomes will be that much good. So I used to advocate to keep a separate port in the center line because the patient is completely draped off. So you need to keep a separate port which is empty and then try to connect an extension line with the drugs loaded, and then we'll keep a separate person. What is it? For the separate person for the job. Okay, for the same thing job. So his job is to keep the drugs loaded. So whenever is the person who is cannulating or who is monitoring the patient, advocates to give a drug, he has to give the particular amount of drug from that particular part of the central line. So you need to keep a separate port in the central line. Try to make sure that you initiate ECMO with the central line only, preferably on the left IJV. Keep all the drugs loaded before you're going for initiation. You need to have an ultrasound machine, which all of us knows. And one more thing which I used to advocate is keep your Vigons ready. Vigons are nothing but your long lateral flex like cannulas. Okay. So these, by keeping these Vigons ready, so whenever you're initiating a VV ECMO also, so if you're initiating it a place other than your hospital, or if you're initiating it in outside place, so I try to advocate to all the juniors saying that you need to keep a femoral arterial line ready, because we don't know when you're going to land up in a complication in a place which is not familiar for you. So if your femoral arterial line is ready with a Vigon placed inside the femoral artery, you can easily convert from a VV to a VA ECMO in case of any complication. If it's not going to land up in any complication, you can use it for the monitoring purposes. You need to keep a femoral arterial ready and always keep an extra arterial cannula ready. We don't know when you're going to land up in a complications. To have a safe ECMO, even though you're going to initiate a VV ECMO, so always make sure that you have an extra arterial cannula. Along with that extra arterial cannula, you need to have the connectors, you need to have the pipes, you need to have all extra things to convert from VV to VA in case if it is required whenever you lands up in a complication. So the management part in initiation is too crucial. You need to maintain all these steps so that to have a safe initiation phase. So all we know, once the initiation is done, is the maintenance. So in the maintenance phase, you have anticoagulation, you have hemodynamic managements, ventilation strategies, and then sedation analysis for the patient. How do you maintain your gas exchange and tissue perfusion along with your general nursing care and management? Coming to anticoagulations, yeah. So it is always a balance between bleeding and thrombosis in the circuit whenever the patient is on ECMO. So you need to anticoagulate the patient to prevent the thrombosis formation, and you need to anticoagulate particularly to a particular point where your bleeding is not going to happen as a complication. So you need to know what are the available drugs in the armamentarium. You need to know which is an ideal drug. Ideal drug is which is cheaply available, which is cheaply titratable, where you can measure the effects of the drug very fast, is an ideal drug. As of now, there is no ideal drug, but I can say unfractionated heparin as an infusion is a near ideal drug in these scenarios. So these are the various anticoagulants which are available for your ECMO maintenance phase. We have a parenteral and oral. Parenteral again direct and indirect acting, oral again direct and indirect. So indirect acting is your unfractionated heparin, low molecular heparin, ponderate, and direct acting parenteral drugs will be direct thrombin inhibitors like Pyridine, biliverdin, argatroban, and then oral direct and indirect. Oral direct thrombin inhibitors you have dabigatran, and then in oral direct inhibitors you have factor 10 inhibitors like rivaroxaban, apixaban, and edoxaban. So these are the various drugs which we are going to discuss now in detail. So first let us discuss about the unfractionated heparin. So this is the most commonly used drug, near normal and ideal drug in this scenario. So it should be given at a bolus of around 50 to 100 units per kg, followed by infusion of 10 to 20 units per kg per hour. So once you start giving bolus, so the bolus should be given once the guide wire is inside. It differs from hospital to hospital, protocol to protocol. Generally, I advocate to give bolus of heparin once the femoral guide wire is inside. So and then it should be titrated to the effect. Okay, it's not always the bolus driven, it should be always the effect driven. Okay, so you should know the conditions where there is an increase or decreased requirements of heparin. There are some conditions where you're going to transfuse blood products, the heparin requirement might increase, and in conditions where you're using it, where there is more diuresis, again your heparin requirement will increase. Use of renal replacement therapies. So whenever the dialysis they're using heparin, again you need to titrate the effects here. Sepsis, as we all know, it's in a bleeding or a coagulate state. So in sepsis, the heparin requirement will come down. Whenever there is a clots in the circuit, and then in conditions like heparin resistance. So these are the various conditions you need to know whether to increase or decrease your heparin dosages, which is titrated to the particular effect. So there are various tests available here actually. We have activated clotting time, we have APTT, you have anti-factor 10A, which is gold standard at this point, and you have TEG also. So out of all these tests, what are the tests you do? So our target should be maintaining an heparin concentration of around 0.1 to 0.25 micro units per ml of blood. So that is your target heparin concentration. So what are the tests you do? So let us see about different tests in detail and about the heparin and then things. So there is one entity called heparin resistance. Once you start using heparin, if you are unable to achieve the desirable effects of your anticoagulation with heparin, so in those conditions, we call it as a heparin resistance. So generally, it is defined as more than 35,000 units of heparin requirement per day, or more than 1,500 units of heparin requirement per hour is called as. In spite of reaching this much amount of dosages, if you are unable to get the titrated effects of your heparin, you are unable to get your desired ACT levels, you call it as heparin resistance. So just before naming the heparin resistance, make sure the antithrombin levels should be normal. So generally it's around 80 to 120 percentage in the normal in adults, and then it is around 44 to 60 percentage in the pediatric population. So once your antithrombin levels are normal, then we can call it as a heparin resistance. Because we cannot measure the antithrombin levels, if you think that the patient is developing heparin resistance or the heparin dosage is increasing day by day, so make sure you give one transfusion of FFP so that you are going to transfuse antithrombin to the patient and then check the ACT levels again. So transfusion of FFP is increasing your ACT levels with the same dose of heparin. It means that it's an antithrombin deficiency in these patients. So what are the measures you do? So once you find heparin resistance, try to make sure that it's not because of deficiency of antithrombin levels. And once that is done, try to increase the dosage of heparin. In spite of that, you are not able to achieve, try to change to other drugs which are available, like direct thrombin inhibitors like bivalirudin and lepiridine and iridine. So as of now in India, generally bivalirudin is most commonly used. So there is one more. This is about the heparin resistance. Another thing comes your heparin-induced thrombocytopenia. There's something entity called as HIT, which is divided into two types, type 1 and type 2. Type 1, as all of us know, which is much more common, which sees within 4 days of the heparin exposure. And then the platelet drops to less than 50% of this baseline value, which comes with less complications and then no need of any aggressive treatment measures here. But if it is heparin-induced thrombocytopenia type 2, which is rare, 0 to 3%, which happens generally after first week or 10 days of your heparin exposure. So again the platelets drops to less than 50% of the baseline value. The only problem with heparin in HIT type 2 is your thromboembolism. So you need to change your heparin anticoagulation strategy from unfractionated heparin to direct thrombin inhibitors, heparinoids or dicomagnetes. So these are the strategies which you are supposed to do if you are landing up in HIT type 2. So let us see what are the advantages and disadvantages of different tests that are available, commercially available tests that measures the anticoagulation efficacy. So if you're using an ACT test, it's a point of care test, it's actually inexpensive, and it's a whole blood test when it comes to advantage. But what's the disadvantage? Actually, it is only measuring the end point of the cascade, but not telling you about the effect of your unfractionated heparin. It's just telling about the end point of the cascade. So it's not mandated that always your heparin effect should match to your ACT levels, okay? Because it's only measuring the effect of the unfractionated heparin, okay? But does not only telling it about it. So coming to APTT, it is an accepted means of titrating when you are using an unfractionated heparin or a direct thrombin inhibitors. And the point of care test, nowadays it's becoming the point of care test. But the problem here is high intra and interpatient variability, especially in case of neonates. So that's a major disadvantage. And then the turnaround times of APTT is very high. Yeah, even the most sophisticated hospital, the turnaround times will comes around 2 to 3 hours. You cannot wait for 2 to 3 hours to titrate the heparin dosages. and anti-10A levels, which is gold standard for measuring your unfractionated hypertonic effect, as I was quoting earlier. So it is better associated with the unfractionated heparin dosages. And but the main disadvantage of measuring anti-10A levels is your elevated plasma-free hemoglobin and hyperbilirubinemia. This will underestimate your activity. Okay, that's the main reason where anti-10A levels is not actually correlating your anticoagulation. Teg and Rotem, yeah, it's a point of care test, whole blood test, and it's very short turnaround times. It provides information about both clot strength and fibrosis, but the only disadvantage being it is limited availability. So once your heparin is done, so whenever you land up in a complication with heparin like HIT type 2 or it might be heparin resistance. So you have your alternatives called as direct thrombin inhibitors. So where we don't need your antithrombin for these effects to happen. So you have Hiridin, Belvaridin, and Gatroban in your drugs. So what are the advantages and disadvantages? The advantages, there is no cross-reactivity and they are active against both free and clot don't thrombin. That's a major advantage of it. There is no requirement of any cofactors for their effect to come. The disadvantage being the cost. Yes, availability and the cost is a major disadvantage. And the difficulty in measuring your anticoagulation effect, APTT is one thing which you can measure the effects of direct thrombin inhibitors effects. Conventional ACT assays are generally unreliable if you are using TTIs, and there is no any reversible agent. And for many clinicians, it is actually an unfamiliar field, unfamiliar drugs. So that is the major disadvantages. When it comes to ergotrogan, you need to give an infusion dose of 0.2 to 10 micrograms per kg per minute. Bivalverin 2.5 up to you can go up to 2.5 mics per kg per minute. And is lepidolin, you can go up to 0.1 to 0.4 mg per kg per hour. So let us see each drug individually. If you see the half-life of bivalverin is very less, 25 minutes, compared to its congeners like argatroban, which is around 50 minutes, and lepidolin is 1.3 hours. Elimination also, bivalverin has got only enzymatic elimination. Most of that, 80% of it is enzymatic elimination, and 20% is renal. If you're using lepidolin, it is a renal elimination. Argatroban is hepatic elimination. Monitoring is same for all of these. Mostly APTT works for these drugs. Thrombin binding is generally reversible if you're using ergatroban, irreversible if you're using lepidolin, and bivalverin is partially reversible. So once you find a toxicity of the patient with bivalverin, or you want to reverse the agent, reverse the effect of this bivalverin, you can try using dialysis because 25% of the drug bivalverin can be dialysable. There is no antidote as of now. So these are the various drugs which are used to maintain your anticoagulation effects when you're going on for ECMO. Coming to hemodynamics, as we all know, your heart rate should be always, there should not be any tachycardia or should not be any bradycardia. Make sure you maintain a normal heart rate, to be less than 110. Target a MAP of more than 65 millimils of mercury. With an urine output more than 0.5 ml per kg per hour, and your lactate should be less than 1 millimoles per liter. And the saturation depends upon the type of it. If you are using a VV ECMO, the saturation target somewhere around 80 to 85 is fine. And if you are using a VA type of ECMO, the saturation will be always 100. So coming to ventilation strategies, so once the patient is on ECMO, once you initiate the ECMO, no need to go for a full ventilation. There is something called as rule of 10, where you keep all the settings with 10, with the least possible FiO2 and with a PEEP of 10, pressure control of 10, and a respiratory rate of 10. That is called as rule of 10. Go with the rest settings on the ventilator with the least possible FiO2, and don't try to forget the monitoring on ventilator. Given the patient is on ECMO, you are supposed to monitor the PEEP values, the compliance of the patient, tidal volumes, PPs which your patient is generating, and the FiO2 daily. Daily try to come down on the least possible FiO2. So monitoring, don't forget to monitor once the patient is on ECMO. Generally, we tend to forget the ventilation strategies, but you need to keep these things also in mind. Coming to sedation and analgesia. So what are our goals for sedation and analgesia? So the main thing is to decrease the pain and anxiety of the patient, decrease the stress response, in a way decreasing your oxygen consumption, and then ventilator synchrony for the patient to avoid neurocognitive sequelae. So if you are maintaining a good sedation for the patients in your ICU, the chances of developing depression, post-traumatic stress disorder, dementia, and then anxiety are very less in these type of patients. And last but not the least, you need to have the family acceptance of this ICU care. You need to show the patient conscious and then trying to obey the commands at least once or twice in 2 days. So the family acceptance also should come to you, right? So this is your goals for sedation and analgesia. So choosing a pharmacology again, there comes the question of ideal agent. So it should have both sedative and analgesic properties, anxiolytic, amnestic, and anticonvulsant. Minimal side effects from CNS side or respiratory side, rapid onset, and then it should also have a rapid offset. no accumulation in case of any dysfunctions. So and it should not have any metabolites. So it should have an inactive metabolites. And it should have less interaction with any other drugs along with the circuit also. So let us see what are the available drugs, because there is no ideal drug. Try to choose the drug which is near to the ideal again. So coming to analgesics which are available right now, we have opioids, we have non-opioids like NSAIDs, ketorolac, we have sedatives like benzodiazepines, propofol, ketamine, etc. And you have other group of drugs like intermediate, barbiturates, volatile agents, haloperidol. We have your antipsychotics, atypical antipsychotics like quetiapine and haloperidol also, and alpha-2 agonists, clonidine and dexmedetomidine, regional anesthesia techniques, and sometimes the paralyzing agents. So I think you are going to have a separate class on sedation anesthesia where the details of each and every drug has been discussed. So I'll go fast from here. So most commonly used opioids, as we all know, it's morphine, fentanyl, and hydrocodone. So of all these things, everyone is very much versed with morphine and fentanyl. So fentanyl is highly lipophilic, where morphine is least lipophilic, and hydrocodone is the least lipophilic as of now. The dose of fentanyl is 0.3 to 0.5 mics per kg every hour. Morphine you can give 2 to 4 mg for every hourly infusions. Also that can be tried. But morphine has got two metabolites, morphine 6 glucuronide and morphine 3 glucuronide, which is actually renally eliminated. So in the case of renal failure, you need to come down on the morphine dosages. But when it comes to fentanyl, there is no need of renal dose adjustments. But the problem with fentanyl is, even though it's easily available and titratable to the effect, the problem with fentanyl is there are so many studies quoting that within 24 hours of starting a fentanyl infusion and then 24 hours of ECMO, and the dosage of fentanyl seen in the patient serum is almost practically zero. So that means that the circuit is completely absorbing the fentanyl dosages which you are delivering within 24 hours of duration. So that's a major disadvantage of fentanyl. So tachyphylaxis happens very fast with that. And then you have hydrocodone also. So these are the most commonly used opioids. So what are the opioid use and what are the sedation scale like Riker scale, Richmond scale, or you have the Ramsey scoring systems. So what are the sedation scores you use? What are the drug you use? So our targets should be the same. If you are using a Riker score, the target of 3 to 4, where the patient should be calm and cooperative, along with it, he is equally sedated. So that is the target if you are using a Riker score. If you are using a RAS score, it should be 0 to -1. Patient will be alert or calm or a little bit drowsy and then easily arousable. Or if you're using a Ramsey scoring system, again, the score of around 3 to 4 is easily, that's acceptable targets in your sedation analysis when it comes to ECMO. Coming to how you optimize your gas exchange and tissue perfusion, as we all know, so you should select an oxygenator that is capable of delivering oxygen, minimum of 6 ml per kg per minute, and it should be equally capable of removing your carbon dioxide. And let us see how we are going to affect this. So if you see this graph here, so the oxygenation is mainly dependent upon your flow and depends upon your oxygenator functioning, hematocrit of the patient, and then again the recirculation of the patient. So let us concentrate on this graph which was shown. So it shows a graph of oxygen consumption and then oxygen delivery. So you need to maintain a ratio between delivery and then the oxygen consumption at least of 4:1, so that your venous oxygen saturation is around 75. So to maintain a venous oxygen saturation of 75, you need to maintain a ratio of at least 4:1 between delivery and then the consumption. As you all know, the consumption is around 240 ml and then the delivery should be around 1000 here. So that's the minimum ratio you're supposed to maintain so that your venous oxygen saturation levels are normal. Okay. So coming to the lower graph here, it's a graph that is plotted between your delivery of oxygen and the blood flow from the oxygenator. So if you see here, with a 1.5 meter square of your oxygenator surface area and the flow of around 2 liters, you are delivering oxygen of only around 100 ml. Okay. So you need to increase the surface area, you need to increase the flow so that the oxygenator should capable of delivering a minimum of around 6 ml per kg per minute, right? So that is our target here. And that's the target of oxygenations here. And coming to hematocrit, you need to maintain a minimum hematocrit of around 40. Try to decrease the recirculation. The maximum available recirculation on any VV ECMO should be around 30%. Coming to carbon dioxide removal, let's see about the CO2 removal. So the CO2 will mainly depends upon your sweep gas flows and then depends upon your blood flows. So any oxygenator which is a normally working oxygenator is capable of removing your carbon dioxide when the blood gas flow to the sweep gas flow is from 1:1 to 1:2 ratios. So more than 1:2, even though if the, say for example your blood flow is around 5 liters, your sweep gas flow is maximum allowable is 10 liters. So more than 10, it's not going to function. That is how the oxygenator is designed. So sweep gas flow is one thing which removes your carbon dioxide, and then your blood flow is also another thing. Need to maintain the ratios. So let us concentrate here in this algorithm till now. So what you have learned, if it is a VV ECMO, say for this is a VV ECMO graph algorithm that is shown here. So try to cannulate the patient with the biggest possible cannulas. So it doesn't mean that you need to keep the cannulas completely occupying the vein. So at least 80% of the vein should be occupied by the cannula, 20% will be minimally free. Otherwise, otherwise you'll end up in complications like venous swellings of the limb, and then the venous flow will be obstructed in these situations. So try to keep the biggest possible cannulas. When you're using a double lumen cannula, the same thing, the biggest possible double lumen cannulas. Try to increase the flow to the maximum, and then with the same ventilator setting, if you're able to maintain a saturation of more than 90, stabilize the flows, okay, and then try to decrease the ventilator settings to the rest settings. After decreasing the rest settings, after stabilizing the flow, the saturation is more than 80, try to maintain it with the least possible flows until the lung improves. Okay. Once you're increasing the flows to the maximum, you're unable to reach a saturation of more than 90. That means that your flow is inadequate. So try to add one more drainage cannula. Or once, even after the flow is adequate, try to treat the hematocrit. Target of hematocrit should be more than 40. And still, if both of these achieved, think of your recirculation fraction. Calculate the recirculation fraction. If it is more than 30, try to adjust the cannulas and see. If you are maintaining a saturation of more than 90, again the same flow chart. It is still less than 90, in spite of doing all possible things. Try to decrease the consumption of oxygen by the patient, either by sedating and paralyzing him, or the patient is in active sepsis. Try to control his temperature, because even active sepsis demands your more oxygen consumption. So these are the things you are supposed to do. In spite of doing everything, the patient saturation is less than 90, try to decrease the consumption of oxygen, decrease the temperature, try to maintain the hypothermia, and try to paralyze the patients in a way, then you can achieve a saturation of more than 80 in a VV ECMO. So this is the blood flow algorithm when it comes to VV. When it comes to VA, again, the same thing. Try to choose the biggest possible cannulas, increase the flows to the maximum, but it's a VA. Then increasing the flows to the maximum, it will be a total bypass here. There will not be any pulse contour. So once that is achieved, you are able to achieve the maximum flows or no pulse contour. Try to come down the least possible flows, which keeps a venous oxygen saturation more than 75. And then try to wean, excuse me, try to wean the cardiac medications, and again here wean to rest ventilatory settings. So while you're weaning the cardiac medications, if you see the patient is developing increased left atrial pressures, or if the patient is having hypoxia, or the patient is developing pulmonary edema, that means that your LA and LV is getting distended. Try to vent your LA, and then once your LA is vent, the problem is done, and then you can do a daily echo and check for the cardiac improvements. Okay, this is one end of the flow chart. If you see the other hand of the flow chart, if you are increasing the flows to the maximum, if you are unable to reach the maximum flows, that means the cannulas are small. Try to add one more cannulas, okay, and then try to maintain the saturation of venous oxygen saturation more than 75, and try to wean the cardiac medications. So while weaning the cardiac thing and patient on rest ventilator settings, the flow is still inadequate. Try to increase the blood volume of the patient by adding a venous cannula, again targeting a hematocrit of more than 10, hemoglobin of more than 10, and do a daily echo. If the patient is improving, that's fine, we need to trial off. If the patient is not improving more than 3 days in spite of all possible maneuvers in VA, in those situations, you need to think of your ventricular assist device or a transplant. So generally, we tend to neglect this nursing care and management. Once you're on ECMO, the initiation part, management part is going to take care very good. But we tend to neglect the nursing care and management, where frequent position change is mandated to prevent your bed sores and back care. Daily checking of your insertion site, like you have to check for the redness, you have to check for the oozing from the cannula sites or any color change in the cannula insertion sites. One more important thing is the temperature difference in your heater cooler unit. So I have seen some centers where perfalgan is given 1 gram TAD and QAD and thinking that there is no temperature. And another thing is they will not monitor the heater cooler unit temperature difference. The first sign or the first sign that gives the patient or the machine tells us is the heater cooler unit temperature difference. So if you see that thing, that means that the patient is going to land up in sepsis in a short duration of time. Tube care and tracheostomy care, bladder and bowel care also is important. So these are the things which I'm quoting here. And apart from all the routine things, you need to check the neurological status of the patient, try to do a daily sedation interruptions, and try to assess the sensorium of the patient. Try to see the hematomas, bed sore, the same thing I'm discussing prior. One more thing is the positioning of the cannulas. You should see the chest X-ray where the cannulas have been positioned. and you need to do a daily ultrasound if you have any doubt in these patients, and the cough tenderness and compartment syndrome. So if you're using a bigger cannulas, no, the venous flow will be hampered, ultimately land up in a DVTs, okay, DVTs and then compartment syndromes. And then the flow in the distal perfusion cannula. One of the patients on VA ECMO, this is the problem which we face. So what we generally do is keep a Y connector here, and then Y connector you have a 3/8 tubing, and from 3/8 there is a step down from 3/8 to 1/4 connector and 1/4 to a distal perfusion connector. So if you are doing this type of arrangement, and if you have a centrimag machine, you can keep the flow sensor here and you can see the distal perfusion flow here. But if you are using a older machines like Rotaflow with the VA ECMOs, so what I generally do, because you don't have a flow sensor which is a mobile thing, so what we generally advocate, every second hourly or every third hourly, try to flush the distal perfusion cannula to make sure that the blood has not been clotted in the distal perfusion cannula. So you're supposed to maintain a distal perfusion cannula of 7 French size. It varies from hospital to hospital, at 7 French, and the minimum of 200 ml per minute is required in the flow in the distal perfusion cannula. Bladder and bowels, the same thing. So coming to monitoring of the machine. So what are the machines you need? What are the things you need to monitor on the ECMO machine? You need to have a documentation of your RPM and LPM, revolutions per minute and liters per minute. You need to see where the power supply is always connected to the UPS part of your power plug, and then the hand crank should be always positioned in parallel to your original pump. Okay, so that the changing of pump it should be easy for you. The hand crank should not be there somewhere else where you cannot do the things within time. And you need to have at least 6 clamps in the bedside of the patient. Don't try to overcome this. So clamps is mandatory here to prevent any catastrophe. As I'm telling earlier, temperature of the heterocooler unit. So the temperature difference in the heterocooler between the set temperature and the patient's blood temperature is very, very much important in monitoring the early sepsis. And then the sweep gas flows. So whatever the amount of sweep gas flow, is it changing or the same? You need to monitor things. You need to monitor the FiO2 on the ECMO. When it comes to ventilator, even the patient is an ECMO, the ventilator monitoring is equally important. You need to check the volumes, you need to check the compliance, you need to check the P peaks of the ventilator. You need to see all the routine parameters in the ventilator to identify the complications. When it comes to circuit, you need to monitor the P pump pressures, pre-membrane pressures, and then the delta pressure, and then the post-membrane pressures like P1, P2, P3. P1 is a pre-pump, P2 is a pre-membrane, delta pressure P3 is your post-membrane. The difference between P2 and P3 is called the delta pressures. Clots in the oxygenator. You need to have a flashlight test daily in your rounds. Okay, at least twice I used to advocate pre and post membrane both sides to find out the clots. And then the tube shattering, you have to optimize the hemodynamics and volume status of the patient. Recirculation, the color change, you need to identify, try to calculate the recirculation once in a while. ABG of the circuit as and when required, and you think that oxygenator is getting failed, you need to check the ABG of the circuit, length of the cannulas where it has been fixed. So you need to check the cannula positionings. That means that, and then auscultation of pump head, which is also very much important. You can identify a clot sitting in oxygenator as early as possible with a simple auscultation technique daily. So try to override those things. So apart from a small note on the biochemical parameters too, apart from the routine lab parameters which we monitor in ICU patients, an ECMO patient warrants to have an our activated clotting time to be monitored. APDT, if you have any discrepancy between your ACT levels, clinical condition, and then the apparent dosage. Chest X-ray for positioning of the cannulas. Platelet counts, you need to check the platelet counts if the patient is going into hemolysis, because the blood is passing through a pressure in the circuit because of pressure drop. You might have some hemolysis. You need to check the platelet counts and LDH in case of any doubt. Try to check the peripheral smear daily, because this gives us a very good information regarding the hemolysis, regarding the sepsis, and then regarding so many things. The peripheral smear is also important apart from the routine things. CRP procalcitonin, it's up to you when you're going to monitor. It's as and when necessary. Pre and post membrane embassy also the same thing. So when you think the oxygenator is getting failed, so in those situations, try to check pre and post membrane ABGs, but make sure while taking your pre and post membrane ABGs, the FiO2 on the ECMO should be always 1. Okay. So with an FiO2 of 1, try to check the pre and post membrane ABGs. So this is the daily checklist which we have developed in our hospital for all the day-to-day doctors. It comes with all the monitoring parameters which are supposed to be monitored when the patient is on ECMO. So try to incorporate this. So we are not going to miss anything in the machine, anything in the patient, anything in the circuit. So because everything is important. And the important part, weaning. So once you're trying to come down to weaning, so your apparent requirement will increase. If it is a VV ECMO, generally will not come down on the flows. If it is a VA ECMO, will come down on the floor a little bit. So when you're coming down on the floors in any type of ECMO, just keep it in mind that your apparent requirement will increase, because the lesser the flow, the higher the chance of clots in the circuit. So you should be very careful with the lung parameters while weaning, because patient tries to take a spontaneous breath, higher chance of a negative intrapleural pressure leading to a pneumothorax kind of scenarios. You need to do a frequent ABGs while monitoring, while weaning the patient. Trial of, if it is getting prolonged, in a VA ECMO, try to incorporate a breach, and even in VV ECMO, it's always a prolonged weaning. And then decannulation. So before decannulation, make sure you stop the heparin at least 2 hours prior, and then you need to do a frequent ACT monitoring for these patients. So only thing I need to stress here is the heparin requirements. So make sure your circuit will not get clotted when you're coming down on the floors. Post weaning, which we generally miss. So once the weaning was done and the cannulars were removed, try to start DVT prophylaxis as early as possible in these patients, and then the mobilization which should be done, wound care at the particular cannula sites, and lower limb Doppler. Once the cannulas were out, try to do a lower limb Doppler within 24 hours. It changes from hospital to hospital, but generally we do a lower limb Doppler for documentation purpose of any DVT, deep venous thrombosis, anything is there in the cannulation limb and all. So check the lower limb Doppler for these patients. Check for again the hematomas, and particularly if it is a VA ECMO, if you are removing an arterial cannula, take the help of surgeon. So we can remove the arterial cannula, but the problem here is there is always a chance of developing a pseudoaneurysm and bleed. So there are instances where patients were lost. So we also lost patients where removal of arterial cannula leading to pseudoaneurysm and rupture. So coming to the take-home message, so every ECMO is different. So don't think that every ECMO is the same monitoring is required. So every ECMO is different. Every step during the ECMO is different. Like is important, whether it's an initiation part, the maintenance part, or the weaning, even the post-weaning part. So every parameter gives us an information prior to developing a complication. Don't try to neglect the parameters which you are giving it. So every parameter is information prior to a complication, and every patient is different. You cannot set the goals the same for every patient. So every patient is different. So be prepared for complications in every step, like I'm mentioning. So you should be prepared for a VA ECMO when you're calculating for a VV ECMO also, right? So once you're counseling the attenders, it should not be only for a VV ECMO. So once the complication develops, be prepared. So once your preparation will save the life of the patient. So the more prepared you are, the more safe the ECMO is. So I'd like to glad to call for any doubts now. Thank you so much for your patience.